Can we have a quick sound off again to make sure we have everybody that's on the line there?
Brett Trolder.
Gina DeGraw.
Laura Van Kelly here.
Brendan Dunn. Eric Sanders.
Great, thanks everybody. Well, we have Dr. Thomas on here. He's our new neurologist taking over our inpatient program here. He wanted to speak, and we wanted to have him speak on a few of some tips for stroke, some of the new process changes we'll see. For those of you who haven't experienced it yet, not much has changed as far as stroke code alerts in our process, but fortunately we do have Dr. on site now for much of this, and he can come see our patients. If he's not on site, he can use telemedicine, and he's building his team to be able to have a more robust inpatient neurology service here to be able to better take care of our population. So with any further ado, I'll leave it up to him so he can get on with his day here. He's going to give us some good points to our current practice and some tips for moving forward.
Thank you. Thank you for inviting me here to have this opportunity to go over some stroke code care. Now, are they able to see me? Oh, they are. Or
No.
they're not?
I'm just videoing you, we can send to them.
Okay, so then it's going to be limited. Or are they be able to see that video later?
Yes.
You can see this as well.
Gotcha. Okay, good. So, do you all have this handout that I was gonna actually pass out today? I thought it's everybody gonna be here. So, but do they all have the copy of this?
Yes, I remember that last night.
So,
Yes.
if you all look at the key information to obtain from the paramedics, patient, or the family, I'm gonna go over that. But before I do that, just brief introduction. TPA was approved in 1996, and then we all know that the timeline for best outcome is within 3 hours. We can stretch that to 4.5 hours from the last known well time. Now, when we tell this to people, sometimes some people think that, okay, so as long as we give it within 3 hours for the best outcome or within 4.5 hours, we're good. But actually the reality is that every 1 minute that passes from the occlusion of the blood vessel in the brain, 2 million brain cells die every 1 minute that passes. So what that means is that the faster we can open that up with TPA or thrombectomy, the better. And so the idea is to give that TPA as soon as possible, 1 minute faster. That counts, but we save 2 million cells when we do that. So the guideline has been initially the target hour from door to TPA bolus was about 60 minutes, and then that was further shortened to 45 minutes. And now they're pushing to shorten it further to under 30 minutes from door to bolus, TPA bolus. And that is because more and more data coming in showing that the faster we give the TPA, the greater the outcome. And many neurologists, including myself, we have seen where people come in with complete hemiparalysis, and the TPA as well as infusing, they are almost all improved. So it's almost, when we see enough of that, we are pretty much convinced that, yeah, TPA does work for a certain population. But we need to be very selective who we give to, because it does have the hemorrhagic conversion risk. And that risk is typically at a good stroke center, it's about 2 to 3%. But overall, United States and including Europe, it gets stretched to up to 6.4%. That's the international average. But within the United States with decent stroke center, it's about 2 to 3%. So when I tell people in getting the consent, I tell them the risk of hemorrhagic conversion is about 2 to 6.4%. So that covers everybody. But once we have enough data here, then we can say in our center, our risk is this and that. So the goal is to be under 3%. But anyway, so hemorrhagic conversion does occur in small cases, but typically they are two particular reasons, and I'll go over that later. So, but to minimize that risk and maximize the benefit, there are a couple of things that we need to get initially as soon as the patient is brought in by the paramedic. And that's on that sheet that I have here. And so these are the information the ED team can collect right away so that we can together decide on the TPA, give or not give right away within the first few minutes. And so first of all, the most important thing, information for all of us, is last known well time. Now this, I wrote that deliberately, last known well time. This is different from symptom onset. Because sometimes the patient or the witnesses may say, okay, the symptoms started 2 hours ago. But then when we ask the question, when was the last time you felt normal? Or when was the last time did you see the patient normal? And that may be 5 hours before, prior to that. And so this is actually the most common reason why hemorrhagic conversion occur, because the wrong last known well time was given. And so this is the most important information. So the way to ask question is, when did the symptoms start? That's the wrong question to ask. The right question to ask is, when were you feeling normal, completely normal? When was that time? Or when did you see that patient normal? And so that's the correct question to ask. And so when you report on the phone to the neurologist, or when you talk among each other with the other team member, always use the term last known well time. And then the other thing is, this is a smaller portion, but I think it's still important. I often hear a report of that time, last known well time, as that was about 1 hour ago, that was about 3 hours ago. But I think the intention is very good, because that helps us to think that I don't have to calculate anymore. He gave me 3 hours ago, so I can go by that. But then what happened is that as time ticks, every minute is no longer 1 hour ago, right? It just time changes. So it's better to just give us the time itself. For example, 1400 or 9 a.m., etc. So you don't need to tell us. It's actually get confusing later on. So don't tell us 1 hour ago, 3 hours ago. Just give us the exact time. Now, if the exact time is unknown, the answer is unknown, which means we cannot give the TPA, right? Now, the next most important thing, and the second most common cause of hemorrhagic conversion, is blood pressure. And so the next question we need to ask is, what was the initial blood pressure? Oftentimes the RAMs out here, they're pretty good in collecting the blood pressure on the field. And so we need that initial blood pressure number, if you can get that, if they have it. If not, then we'll get it in the ED or in the CT scan while the CT is being done. This is important for us to decide whether to start preparing for nicotine drip right away. So nicotine drip should be, if the initial blood pressure is around 180, hovering around 185, 180, then we should be already thinking, okay, labetalol one time and immediately followed by nicotine drip. That should be in our head already. But the initial blood pressure reported as 130, 140, then we don't have to think about that right now, right? And so that's why it's important, because one of the most common reasons of delaying the TPA is trying to get that blood pressure down. And what happened is the blood pressure is 190, etc., and then you give one labetalol IV, 10 milligram perhaps, and then it doesn't go down. Perhaps go down maybe a tiny bit. So you give another one after 10 minutes. You give another one, and you wait for another 5-10 minutes, and you give another one, and then think about the nicotine drip. By then, we have lost about 25 minutes. Remember, every 1 minute is 2 million brain cells. So 25 minutes is a large number of brain cells. So the way to do it is, if the initial blood pressure reported is already 179, 185, 190, we're thinking nicotine drip right away. And then so give that labetalol, and then after one shot of labetalol, already have the ready for a nicotine drip, so that we can initiate it in the CT scan if the blood pressure keep hovering up. Next thing to ask is the glucose. This is in fact the only lab that we need to decide on the TPA. They got rid of all the other coag requirement, all that, so the glucose is the only thing we need. And oftentimes the RAMs out here are pretty good at having that finger stick glucose on the field, and that's the number that we want.
Dr. McMillan. Sorry.
Hi, Dr. McMillan.
Another one of doxycytine.
Yeah, oh, okay, gotcha. So now, however, even if the glucose is over 400 or lower than 50, we still think about the TPA, and it can still be given if the deficit is clearly localizing on one part of the brain. And so in the past, If glucose is greater than 400 or less than 50, it was a contraindication to TPA, but that's gotten rid of. The only other lab that I would say is useful is sodium level, because oftentimes when sodium is 120 or below, people get confused, they're kind of drowsy. So that sometimes is very useful, especially when we have a patient who are confused. However, sodium is not required. Now the next question that we need to decide on the TPA is the blood thinner. So that's the next question you want to ask. Is the patient on any kind of blood thinner? As you know, the antiplatelet, aspirin, Plavix, Brilinta, none of these are contraindicated for TPA. Even if they're taking all three combinations, it's not a contraindication of TPA. But what we are looking for is anticoagulation. Coumadin, Pradaxa, Eliquis, or Xarelto. Now, question is, when did they take that? So if they say, yeah, I do take the anticoagulation, next question is, when was the last dose you took? If it's within 48 hours, we cannot give the TPA. If it's Coumadin, or heparin, or Lovenox, even if it's within 24 hours, we may still be able to give it if INR or APTT is within the parameter. And the INR cutoff is 1.7 or higher. And so, if the patient say, yeah, I take Coumadin, I took it yesterday, we want to get that INR right away. But it has to be serum. The finger stick point of care is very inaccurate, so we cannot go by that. So it has to be serum. And it looks like it takes about 20 minutes to get that result. So we want to get that INR right away. So, last known amount of time, initial blood pressure, and is the patient taking anticoagulation? Those are the most important questions. Those three questions will help us to decide right away whether TPA should be given or not. And then the next stuff are more extra stuff that we can ask if the patient or the family member there can provide a history that's prior stroke. And if there is prior stroke, when was it? Any past brain bleed, any kind of brain mass, brain aneurysm, any kind of brain malformations. These things can be gone over by the neurologist, so you don't really have to ask those questions because it may take you time and delay the time for CTA, but this is just to kind of give you an information of what are some of the things that neurologists need to ask. The other additional question we ask is any kind of major surgery, any kind of major head injury with concussion. And if they said, yeah, I had a stroke, we ask, did you get the TPA in the past? Okay. Now, in terms of old stroke, what's the parameter? Any stroke longer than 3 months, we can still give the TPA. Older than 3 months, we can still give the TPA. And then aneurysm. Sometimes aneurysm is not an absolute contraindication to TPA. Even if the aneurysm is there, if it's not giant or large, which is greater than 10 millimeter, if it's less than that and it's secured and it never ruptured, then we may still give the TPA. But that's the more complex decision the neurologist will have to make. Now the next thing that we need information from the ED team is what are the major deficits? Most important thing obvious is which side is it? That's very important because when you tell me it's the left side or the right side, I am looking at the opposite side on the CT scan and on the CTA, trying to look for the abnormality on that side. Because I don't have time to look for both sides, right? So when you say left side deficit, I'm looking at the right side on the CT scan to see if there's any changes there. So that's which side is very important. And then, does the patient have a headache? Is the patient complaining of headache? That's important because that can tell us that it may be a hemorrhagic stroke. Okay, so we may hold off on the TPA. And then also it may be a subarachnoid hemorrhage, SAH. And so headache, do you have a headache along with that symptom, or before the symptom, or after the symptom? That's very important. And then So in talking about this, I wanted to talk about the quick NIH, how to do it, how do we do it effectively in a much shorter time than what they show it on the video, national education video. That's actually from my medical school, UCSD. But it's wonderful, it's great, but that's more designed for after TPA decision is taken care and you have plenty of time to do it, so it takes about 10-15 minutes. We do not want to do that when we are still trying to decide on the TPA. We want to do it within 2-3 minutes. How do we do that? Well, I'm going to go over that. So hopefully everybody can look at that video later. And this is, I'm going over this thing after observing a lot of people doing it in the ED, and I try to figure out what will be the most effective way to do it. First of all, there are 11 items on the NIH, but that does not mean that you have to go through 1 to 11 step by step. You can jump, and you can do multiple at the same time. So I'll tell you what that means. So first, one item, 1A, 1B, 1C, is checking the consciousness, understanding, ability to express himself, so aphasia. And also there is a speech, which is number 10. And then the eye motion, which is item 2, number 2. All of this, awareness, alertness, ability to understand, ability to speak, express himself, eye movement, can all be taken within the first few seconds the patient walk into the room by paramedics. You watch, as the patient is coming in, watch this face, watch your face. Is the patient looking around? So you always check eye movement, right? The patient looking around, most of the time they are anxious, so as they're wheeled in to the ED, they will be looking to the side. So you check the eye movement already. And the patient is aware, alert. And so you ask the first question, what's your name? Patient is able to answer. Then you check already, comprehension is intact, and the patient is able to speak the name. So aphasia is taken care of, right? And then you ask, how old are you? Sometimes, very elderly people may not know that, so that's understandable. That may be their baseline. But so you kind of have to understand that. So name is the best thing to ask. And then you ask, what happened? What do you feel? And if they can explain what happened, that already take care of the aphasia question down below with the picture with the in the kitchen, the cookie jar and all that. You don't have to do that because the patient is able to explain the situation. This morning I was doing this and I felt this. That's situational understanding and expression. So that take care of it. So first question, what's your name? What happened? What do you feel? And then patient able to answer or not. That take care of all of those aspects. And then if you notice that the patient didn't really look around, to look straight, so now you just have to check the eye movement. The eye movement we check is not up and down. We are only interested in the horizontal motion. Can the patient look to the left and look to the right? How far, complete or incomplete? Why is that important in deciding the TPA? Well, besides the one-sided weakness on the face and the arm and leg, if the eye conjugate gaze is not paralyzed or incomplete, that tells us that stroke also involves the frontal lobe. Because the frontal lobe is what controls the eye movement to the contralateral side. And so that also tells us that patient having a seizure or not. So just real quick, if the stroke is on the left side, the frontal lobe on the left will normally cause the eye to move to the right. So now that there is a dysfunction due to the stroke, the eye cannot move to the right side, so it deviates to the left. If there is and then the symptom deficit will be on the right side, motor deficit. So the eye will be deviated the opposite of the motor deficit. So there's the opposite eye movement from the motor deficit. That means it's a stroke. In case of a seizure, there's a hyperactivity on that side. The eye will be strongly deviated to the hyperactive eye, so it will move to the right side. And then the weakness or stiffness will be on the same side. So if the eye deviation and the stiffness or inability to move the limb is on the same side, that indicates the seizure activity. That's one reason. Second reason why we care about the horizontal eye motion is because it tells us that stroke not only may involve the basal ganglia or brainstem, etc., but also the frontal lobe. That means that stroke may be much bigger. So it tells us the size of the stroke. So that's why it's important. And then after that, you check the show me your teeth or smile, right? If the patient can follow that simple command, that also checks the comprehensive aphasia aspect. So you don't have to check later again. And then you ask the arm. So basically we're going down from the top down in order. So you ask the patient, smile or show me your teeth, you follow, good. I check that, and I also check the patient can understand and follow the command. Next is the arm. So when you do the arm, you don't need to try to do this complex test. This is more of a complex test, and it's not part of the NIH. So we are not looking for the pronator drip. And the reason why I say that is because it takes a lot of effort and explanation. Sometimes patients don't understand. When you say try to keep the palm up, and if they don't understand it takes time, you lose minutes. So to just say, you just grab the patient's arm. First, if you're not yet sure if the patient can follow command, then you try again without showing, so that the patient is not just mimicking. Just say, raise your arms, hold up your arm in front of you, and the patient follow. Good, you test that. But if you already know the patient is following command, hold the arm and put it about right here in the front, and then let go. As soon as you let go, you count 1. Sometimes it's helpful to kind of show it in front of the face so that the patient can understand that he needs to keep it up. So 1. So how long? 10 seconds. Why do you keep it up 2 hands together, not just 1 at a time? Well, there's a couple of reasons. 1, you save time. You save 10 seconds. And then second, if there is a slight trip, you can tell immediately because there's something to compare to. Okay, so that's the reason. So you hold it up, put it right here, okay, and then you give the command, okay, keep it right here, don't let it go. 1, 2, 3, 4, 5, so 10 seconds. And then as soon as you see that it's ripping, you already know. But you can tell right away that the patient will be able to hold it up, but it just drip. Then you don't need to keep count up to 10. You already know. So you can stop counting, okay, got it. And then now the next thing is the leg. The leg has to be 1 at a time, not both at a time, because it's extremely difficult to put both legs at the same time. So same thing. By this time, same thing. If you're not sure patient is able to follow command, you try one more time. Lift up your left leg. So you can decide, lift up the left leg, lift up the right leg. The patient able to follow, that means that patient not only able to follow command and do it, but also understand left and the right. Right? So if you already know that, you don't have to do that. Just to save time, just grab the leg, hold it up about 30 degrees, and give the instruction, okay, keep it right here. And then you let it go. And then as soon as you let it go, you count. 1, 2, 3, 4, 5. So leg is 5. I've seen some people do leg 10 seconds, but leg is 5 seconds, arm is a 10 second. And then you do 1 at a time on that one, on the legs. So arms together at the same time, legs separately. So after that, you do the finger to nose. Oftentimes, this is missed, but the reason why it's important is this test is one of the very few. The other one is the speech, dysarthria. Dysarthria and finger to nose and heel to shin are the only tests that exist on NIH to determine if there's a stroke in the posterior region. So NIH is really designed more for the anterior blood vessel, MCA, ACA territory, not so much the posterior. So if you don't do the finger stick, you may miss that stroke over there in the back. So it's important to do it. There's a fast way to do it, the correct way to do it, and that is you can demonstrate to the patient, okay, nose to my finger, do this, and then put it up here. But don't put the finger like this, because then sometimes patients think that, okay, touch right here or touch right here. They don't know where to touch. So put the finger like this, so what they see is your fingertip. And it has to be far away from the patient so that when the patient reach out to that finger, it's not just right here. Because the ataxia from cerebral stroke occur at the end, toward the end, so not over here. So if you do it too close right here, and the patient go like this, you will say, okay, it's intact. But actually, when you do it outstretched, it may show up at the end. So make sure the patient is out reaching for that finger. And so finger to nose on both sides, that shouldn't take more than a few seconds. And then if there is a ataxia on the finger, then you move on to heel to shin. But if there is no ataxia on the finger, you can skip the leg, heel to shin. Why do I say that? Because heel to shin takes time. It takes time to explain how to do it, how to demonstrate it. Oftentimes, multiple times, the patient don't understand. But in case you do it, the easiest way to do it is demonstrate it to the patient yourself. Okay, look at me. Do this right here. Do this, and then put the heel there, and then show them how to do it straight up and down. So instead of explaining, it's better to just show it. This is how you do it. Okay, do it like this. Okay. But if there is no ataxia on the finger to nose, you can skip the heel to shin. The reason for that is oftentimes cerebral stroke causing ataxia will affect both the upper and the lower extremity at the same time. Okay? And then the next thing, visual field. This is important because a lot of time, because of that national video from UCSD, a lot of time what people do is a very complex method that takes a lot of time. That is, cover one eye, and then they show number of fingers, 1, 2, sometimes even 3. And so they do this, and each eye, 1, 2, 3. So that's beautiful, but that's when you have a lot of time. So in a case of stroke, every minute count, we want to do it quickly. The best way, quickest way to do it is just have the both eye open. Because stroke-related visual field cut is always on both eyes. So you want to test both eyes at the same time. And then have the patient look at your nose, and then say, okay, look at my nose. On your peripheral vision, show me which finger is moving. And so you need to be able to look at it yourself, and then go like this. Okay, point to the finger that's moving. So you test the either quadrant, lower and upper. So you can change the order from lower, you do it here, and then upper, you do it here, like that. Done. Takes a few seconds, no more than 5 seconds maybe. So the fingers, that's the important one. And why is that important not to skip? Because that test is the only test to tell us if there is occipital lobe stroke. Because occipital lobe stroke will only have, oftentimes, the only deficit is the visual field cut. There's no other deficit. So if you didn't do it, everything else came back NIH of 0, but you didn't do the visual field cut, you missed the occipital stroke. Sometimes that could be pretty large, and yet the only deficit is the visual field cut. Okay. And then the sensation. Obviously, we're not going to give TPA for sensation deficit, even if it's a complete hemibody, complete numbness. I don't give the TPA for that, because the only concept of giving TPA is it disabling or not? That's the criteria of giving the TPA. It's not how big the NIH score is. It's not how small NIH score is. So it's a question of, is it disabling for this patient? So NIH score may be 2. And that 2 for that patient may be extreme dysarthria. But that patient occupation is a radio station talk show host, or telemarketer, or even physician, who for him the communication is key. And so he cannot engage in that occupation anymore. But NIH is only 2. So if we go by NIH score, we will say, hey, that's only 2, why not give TPA? Let's not give it. But if we go by, is it disabling for that patient? The answer is yes. And so oftentimes some people think that NIH is what decide, NIH score high or low is what decide the TPA or not, but that's wrong. NIH is not designed for that. NIH score is designed for giving the idea of how big is the stroke and where is it located. That's its function, and it's not even doing it well. It's only doing it well for the anterior portion of the brain. So NIH is not a perfect score, and it should not be used for TPA. So it should be, if you notice the patient is drooping and dysarthric, if it's a 80-year-old, 90-year-old retired completely retired, no longer engaged in any kind of occupation, we may have a discussion, okay, TPA has a risk, do you want it or not? But if it's a young person who need to communicate in his occupation, I would say, I would strongly recommend getting the TPA, okay? So, but NIH is only 2. Same thing, right arm, complete paralysis, that's NIH of 4. Some people don't give TPA if NIH is less than 5. Some people say less than 8, don't give TPA. This is usually especially from some of the emergency medicine community. But what I'm trying to show you is NIH of 4 is complete paralysis, not even able to move the finger, and that's NIH of 4 on the right hand. And that patient's job is the truck driver. Now he cannot shift that gear. So what now? So it's completely disabling for that patient, but NIH is low. So it makes sense to decide the TPA based on the disability. Okay. So sensation test, how do you do it? The fastest way to do it is go face, hand, and then feet. So you do the light touch like this once, or no more than twice at the same time, and say, does that feel the same? Patient often say yes. Or the patient often say no. You know already that there is some deficit on one side, the US. Is that more here? So you kind of clarify that. But idea is to touch together at the same time, but no more than twice. Why do I say that? Because if you keep doing like this until the patient answers, that's not an accurate sensation test. So you just go like, okay, was that same on both sides? Yes. And then you move on to the hand. Was that same on both sides? And then feet, and you're done. So all of these, so by doing these tests, you covered all NIH already. And it usually takes no more than 2 to 3 minutes. Okay. And then in terms of scoring, I don't want you to get caught up in trying to add up all numbers and ask people, hey, what was that total? Don't worry about it. When you talk to neurologists on the phone or in person, all you got to do is just tell us, okay, what did you see? What was your exam? And then we can add the number in our head. So don't spend time trying to add up all the numbers or calculate. So we'll do that. But what's important is that you do this simple, quick NIH, and then you can communicate that to us, and we'll add up the number. And that will also help us to kind of TPA decision should be made between the ED doctor and the neurologist. Part of the reason is that oftentimes some patients have complete aphasia, they cannot comprehend, they're not capable of making the decision, and oftentimes there is no family member that we can contact right away. So the decision ends up being between 2 physicians, which will be emergency room doctor and the neurologist. So that's why it's, when we talk on the phone, initially after you're done with the exam and you send the patient away to the CT scan, the neurologist will be on the phone, and then you communicate what you found, all this information that we went over, and then that will help the neurologist say, okay, I think the TPA is indicated, TPA is not indicated. If it's indicated, we'll say, okay, if the CT scan does not show bleeding or any clear indication of near complete infarct, which is hypodensity, let's give the TPA. So we set up a preliminary plan right there.